Now, here's Dr. Larry.
Did you know? Let's go.
You've waited all week.
Every week, we continue to learn how to achieve a better back and ultimately better health.
Live in the WIKB studios, this is Dr. Larry.
Well, hell, thank you for hitting the flex capacitor, Tim. Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we talked about whiplash. It was an important week to be tuned in because we learned and defined about this type of trauma because, let's face it, it carries a bit of drama. So, here it is again. Whiplash. It's quite the bash. Against ligaments, muscles, nerves, and more, whiplash can leave you feeling super sore. So what is whiplash? Who gets it? How do you get it? How do you fix it? It's the whiplash bash. And no, it's not an 80s rock concert, just whiplash. The kind that causes an injury and not a rash. Have you ever had it? How do you know if you did or did not? What is true whiplash and how to treat it in a flash? A middle-aged mom checked herself into my office. She was struck from behind as she was stationary in her vehicle waiting to turn left off of US 2. The other driver was going at a high rate of speed, around 60 miles an hour. Distracted was the excuse, and smashed directly into the rear of my patient's vehicle. And thankfully, no fatalities in either case. But the result was whiplash. In another case, a patient was driving near Econo Foods in Iron Mountain. She was gliding to a stop at the stoplight and, bang, was struck from behind. Both vehicles were moving, one going at a little lower rate of speed than the other. No fatalities, thankfully. However, the patient who was struck suffered whiplash. And finally, in a third unusual circumstance, two patients were driving. One pulling out of Walmart to head home to Iron County. The other was driving at a normal rate of speed to head home to Iron County as well. And the one pulled out in front of the other and side impact to one car, front impact to the other car. So my question then to everybody is, which patient suffered from whiplash? So let's frame in what is whiplash. Do you always have to be in an auto accident to get it, or can you get it from a slip and fall? Football or baseball? How about a long day of fishing or blowing out candles on a birthday wishing? Let's quickly define just what whiplash is, and then we're going to expand it so we have it. Whiplash is a neck injury that happens when the head is suddenly thrown backwards and then forward, sometimes side to side, with enough force that the soft tissues around the neck, the muscle, ligaments, tendons, get overstretched and strained. It's most commonly associated with car accidents, especially rear-end collisions, but it can also happen in sports injuries, falls, work accidents, or a sudden jolt, or yes, as Jim asked me last week, the mosh pit. The overall mechanism is the rapid acceleration and deceleration. That's the key because you're going to hear in this review in just a moment as a reminder that it's not always in the neck. In plain English, the body moves forward one way, head lags behind, and then snaps back in the opposite direction. So that sudden motion can create bad stress on muscles, ligaments, tendons, joints, discs, and nerves in the cervical spine. Even a crash that does not look dramatic on the outside can create enough force and injury to the neck. One research cluster says around 8 miles an hour, and that's not that fast where you can sustain some level of whiplash. Common structures, you heard me talk about it and touch on a little bit. Tendons, joints in the neck, discs, nerve roots, sometimes the jaw, shoulders, and upper thoracic region as well. Symptoms, they don't always show up immediately, especially with whiplash. Some people feel the pain right away, while others it delay. But here's just the rattle off of the symptoms so you know. Neck pain, stiffness, reduced range of motion, headaches starting at the base of the skull and wrap around like a headband, shoulder upper back pain, muscle tightness spasms, dizziness, fatigue, pain between your shoulder blades, tingling or numbness into the arm or hand in some cases, but not always a pinched nerve, trouble concentrating, and foggy feeling in your brain. That's whiplash. So it's beyond just a little bit of a sore neck. It's a real acceleration and deceleration. It's the combination that can affect several of these important structures, headaches being a big factor long-term, and some nerve irritation as well too. So that's a basic definition. That got us warmed up last week and for the review. Humanly, though, we think whiplash should be almost as over as quickly as it starts. Sore for a few days and then good to go. And that is true in certain cases. But what about the lingering whiplash? How long can it linger? Reminds me of the Cranberry song from the 90s. Can you get whiplash, though, anywhere else into the spine? In the first case, I didn't get the patient until 6 months after the fact. Clearly a case of whiplash. And also, I'm going to let you know how can a clinician know if you have whiplash or just basic neck pain. All of her main symptoms went away. She was properly treated by a physical therapist for months, but still a few symptoms remained, and I'll let you know what those are. And by the way, a side comment, this case should have been referred to a chiropractor after PT was done, but unfortunately some PTs are still not cooperative with continuity of care to chiropractors. This is not just a lack of awareness, it's a lack of professionalism at the cost of you, the patient. So the patient was treated on referral, but the job was not done and remnants of whiplash remained, and here they were. Headaches, tension style like a hat band, neck stiffness to one side, and the rest was fine, and dizziness. So the onset of injury and these symptoms were still there 6 months later and not going away. I have seen them up to years later, whiplash lingering. So now what about imaging? Often not much. Plain x-rays are useful to rule out fracture, dislocation, gross instability, etc. CT scan is excellent for bone injury again, but not proving the pain source and routine whiplash. An MRI can sometimes show disc injury, swelling, some other soft tissue findings, but many patients with real whiplash do not have a overly dramatic imaging, and that's the truth. So in many cases, whiplash imaging is more helpful for ruling out the dangerous problems, more so than proving if it's whiplash itself. That's why it's still primarily a clinical diagnosis that, catch this, if you're a fan and listener of the show, you know that's why I repeat this stuff often. History, mechanism of injury, symptoms, physical exam findings, and exclusion of other serious pathology. So there's not one magic scan that lights up and says, whiplash here. Now, do we have any objective diagnostic tests at all? There are some, but they're extremely limited. So the scan might be quiet. The pain is still real. The x-rays might be clean, but the joints might be injured. So let's make this realistic. The 40-year-old patient struck around 60 miles an hour. This is, by the way, a way back. This is not a tap, it's not a bump, it's a force with speed, and the speed with consequence. At first, the patient had all the classic symptoms. Fast forward 6 months, those 3 symptoms remain. Why are they still hurting? Why hasn't it healed yet? And those are very valid questions that we went into last week when we did the whole show. So the key, though, some of the whiplash symptoms for dizziness, and I want to kind of square this in for you a little bit. In dizziness, we think inner ear, we think crystals got messed up, so it's vertigo, we think brain or even anxiety, but the neck itself, especially the upper neck, also the trapezius area, the trap area, that lets the head know where it's at in space. So in a whiplash situation, things get disrupted, and now those sensors kind of don't know where you're at. You are almost like disoriented, like a pilot that's upside down in the clouds and doesn't know that they're upside down. Kind of a scary thought, but that's exactly some of the distorted mechanisms that happen in whiplash, and that's why people don't have like a spatial awareness and even a little bit of fogginess too when it comes to whiplash cases. So the crash ends fast. The scan may look clean, but the symptoms still look mean. Now, where else can the whiplash happen? And the term itself, of course, when we hear whiplash, we think neck. But if you just take and remove the label, I say remove personalities and opinions, get rid of the label. If you get rid of the label and just define it by the mechanism, it's the acceleration and deceleration. So anytime you have that, you can have the mechanism of whiplash. That means in the thoracic spine. That means in the lower back. You could also make a statement that it could happen in hips, shoulders, the whiplash mechanism. When patients come in and they've had, let's say, an example, I had a case this year of a very nasty slip and fall on black ice, and the lady literally feet went out and she whacked the middle part of her back, head snapped back, but also so did her thoracic spine, and her main symptoms were whiplash style symptoms throughout her neck, her thoracic, and her lumbar spine. But again, understanding, and this is kind of how I explained it to her, how I'm explaining it to you, the whiplash can happen anywhere in your spine. So those symptoms can happen too, tingling into the legs instead of the arms. You can't have a headache in your lower back, but you can certainly have some bone aches in your lower back. Football tackle, of course. I mentioned the mosh pit last week. Jim brought it up. Wrestling, shoved unexpectedly. I had an unfortunate situation where I had to be an expert witness as far as evaluator on a domestic case, had to testify and be cross-examined actually by the guy that was the offender for the female. And part of the situation was I had to go over some of the whiplash mechanism. And in fact, there's, if you can say, a little bit of a relief valve on that one. When he cross-examined me, this is just for all of you, he said, in your notes here, Dr. Larry, it says here that a lot of the treatments you did were in her upper back, yet she's having neck problems. And how can you actually say that? And I said, well, if you step on a dog's tail, it barks, right? So when you shoved her in the back and her neck went back, that's what happened. So that's why she had back pains, that working up her back. And he said, no further questions. And that was done at that day. So little side comment there. Unfortunately, the case didn't go as well for the plaintiff. But anyway, so that's where whiplash can happen. Those are some of the things that the mechanism of it. I wanted to do that show last week because it's not like people come in to their doctor and they come out going, oh yeah, it's whiplash in my neck or thoracic. It's still kind of not as a common diagnosis that I see, but a common mechanism that I see. There was more. However, if you missed the entire show and want to be more in the know, then log on to my website, drlarryradio.com, hit the subscribe button, follow the links, and listen to my show. They've been uploaded now, which you can listen to at your leisure as a podcast. And here is the final point. If you think you have whiplash, call your local chiropractor in a flash. Now, beyond that, in addition to the Devo, did you catch it, Tim? You must whip it. Last week, we learned a simple self-test for neck noise. It was another Dr. Larry cool tool, and you can call my office for a freebie reminder just in case you're in need of a retip or a tip up. And so that was last week. Yeah. Now today we'll forget that monologue for a moment and keep remembering those mandatory communication skills all doctors must have, which are inquisitive listening and staying positive. Again, it often means the difference between sick and well. Also, it's another month of the year, so let's keep what are we going to keep in gear? Our wrists in gear. So in our tip and trick segment today, we're going to learn a simple self-test for carpal tunnel. You're going to be a pro at this by the time the year's over. And of course, you snap into a Tim are calling out right from the broadcast booth while we crank up the tunes and I hit the center stage for the demo. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge to the game, because today we're going to talk about, hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
Surgery. And your lower back. What type of surgery can get you back on track? Or when should you have surgery for your lower spine? Is it as bad as we usually think? Or can we get your life back in sync? Back surgery and back surgeons. Let's dive deep on the subject like trying to fish for sturgeons when we get back from the break. Stay tuned. You're listening to the Dr. Larry Radio Show.
Dr. Larry will be back in a moment.
What's cooking in your community? Head to one of these fine establishments for your next bite or beverage. Alpha Michigan Brewing Company on the Circle and Alpha opens at 4 Wednesday through Friday and noon on Saturdays and Sundays. Call 920-358-9551 or go to alphamichiganbeer.com or Facebook for tap menu and events.
The Habit Bar and Grill, Highway A in Nelma, Wisconsin on the Snowmobile Trail and offering premium gas and daily specials. Open 10 a.m. 7 days a week. Call The Habit, 715-545-2646.
The Horseshoe Bar, downtown Amasa, opens at noon, 7 days a week. Burgers, sandwiches, nachos, crazy broad specialty homemade pizzas, and deep fryer snacks too. It always tastes better at the Horseshoe Bar, downtown Amasa.
The Local Eats List from your friends at WIKB WFER.
I would never recommend buying a home without having the water tested first. It's cool, it's clear, it looks clean. Oh, it tastes good. Well, what's really in it? And we just recommend that you check it out. I'm Jennifer Toivonen. I'm a co-lab director at Whitewater Associates of Amasa. Coliform bacteria, lead, arsenic, nitrates. You want to be sure that water is safe. I would recommend giving us a call. That way we can tailor the kit that we send to you for what you need. 906-822-7889. Give us a call.
This is Mason from Iron River, and you're listening to Dr. Larry Radio.
Michigan kratom could be banned. Lawmakers are pushing House Bill 5537. This could make kratom illegal to buy, sell, or even possess. Call your senator at 517-373-7840. Paid ad by LSD Smoke Shop. Check out LSD on Facebook for more info.
Break's over. Time to get cracking once again with Dr. Larry.
Timmy, way to go, buddy. Uncle Tim's on the 1 and 2. Surgery. Roughly 1 to 3% of the patients I see need some type of low back surgery. In fact, some of you listening right now may have already had one. You may be on your way to needing one, or you may know someone who has had some type of back surgery. Based on that, some awareness of the types of back surgeries is appropriate because it will help you understand what someone you know has gone through or you might be about to go through. So here's the outline of the show. We're going to go over the 3 types of back surgeries first. The characteristics of back surgeons. I'm talking about characteristics of the style of surgeon and characteristics of the personality of the surgeon. Sounds like Chuck Woolery dating game show. Failed back surgeries, what is that? And how to make sure you are properly screened for a back surgery. So there are 3 basic types of low back surgeries done. Discectomies, laminectomies, and fusion surgeries. I'm going to go through each type, what it is, why it's done, and what I've witnessed as far as how patients have recovered from these types of surgeries. So when I say what I've witnessed, dealing with spine problems all day long, there's a volume of cases that come in, and then over a career, you get to see firsthand thousands of these types of post-surgical outcomes. So what I've witnessed, eyeball to eyeball, what I've seen as far as the surgery goes, and to hopefully shed a little bit of a light on for you of what it looks like. Even if you know 5 people that have had surgery, even if you know if you've had 1 surgery or 2 surgeries yourself, this kind of puts it all into a framework of the masses. So first, let's go over discectomy. What is it? A lumbar discectomy is the type of surgery to fix a disc in the lower back. It's a basic hitting drill. Sometimes the outer wall of these discs may dry out and weaken with age or injury. And when this happens, the soft, squishy inner part of the disc bulges out. This is called a bulged or herniated disc. By the way, you can have a bulged disc and still be asymptomatic, so bulging disc doesn't necessarily mean bad thing. But a bulged disc or herniated disc, when it presses up against either spinal cord, spinal nerves, can cause pain, tingling, weakness in nearby parts of the body. During a minimally invasive lumbar discectomy, the surgeon takes out part of the damaged disc, just like the old game of operation. This helps ease the pressure on the area. Your surgeon can use different methods to do this. One method, they insert a small tube through the skin of your back between the vertebrae and into the space where the herniated disc is. He or she then inserts a little tiny tool through that tube to remove a part of the disc. Very rarely, but on certain occasions, a laser might be used to remove that part of the disc as well too. So the surgeon just makes a very small skin incision and does not have to remove any bone or muscle. They have to cut muscle, but they don't have to remove it. Now my observation is this. Overall, this is probably the best type of low back surgery for a few reasons. Number one, it's typically the least invasive, no-brainer. And what I mean, though, is there is less cutting of the muscle. That's a lot of times where there's some recovery issues, is cutting through a lot of muscle when it comes to back surgeries and cutting through a lot of ligament and other soft tissues. So the less tissue that's removed or cut, naturally, the least invasive is going to be the quicker heal time. Number two, it tends to provide some fairly instant relief in a lot of cases. So usually I'd see, and it also has the least complications. Overall, and this data backs it up, so I'm backing up what I see observationally as well too for out there. It's about an 80-90% improvement for most patients. Can there be problems? Yes. Rare, but I've witnessed it and I've seen it, is disc collapse due to instability. So think about a meniscus in a knee. You shave off a little bit of meniscus in the knee, symptoms go away, and patient's fine, and then jars the knee again, and then bang, you blow out an ACL. Well, the same thing can happen with a discectomy in the lower back. Take out enough of the disc, the cushion's gone, you feel great, you go back to your normal activities of daily living, you twist one way, and bang, all of a sudden the disc collapses. That happened to a patient 3 weeks after a discectomy, had to have an emergency fusion surgery. Now the patient's stable, but went from feeling really good after a minimally invasive surgery to a major surgery and 6 months off of work. That's how quickly, in a circumstance, a minor surgery can turn into a major situation and off work. That's what I've witnessed. The second is a laminectomy. That's the roto-rooter type of surgery. So that creates a little space by removing parts of a arc portion of the vertebrae. Now we're digging away at some bone that covers or houses some of the spinal canal. It's also known as a decompression surgery. Laminectomy enlarges, rotor-rooters, your spinal canal to relieve pressure on the spinal cord or nerve roots. And I find that patients often even kind of know this slang term. I think I need my spine rotor-rooter, Dr. Larry. So why, though, would you need this? Well, the big term is stenosis, or narrowing. That's what that terminology means. And this is common degenerative process, stenosis is, that occurs with aging. Can occur from, what type of lifestyle you led as well. But the area inside the spinal canal gets smaller as bone spurs form and the ligaments thicken. Now, I can run past that ligament thickening term pretty quick because it doesn't get a lot of attention, but I will tell you in cases of stenosis, what I've witnessed and seen is the ligament part around the spine, when it thickens and buckles, can be a major source of pain for patients. And that's where non-surgical lumbar decompression can come in, and that's a whole nother discussion to have on that. But I want to stick with the surgical side of things. Also, side note, as some of you may know, 5 years ago, I was invited out to Mayo Clinic, and as I was meeting a lot of the doctors, one doctor actually removed the portion of the ligament. And when we had this discussion, he was in between procedures, he was talking to his staff, they introduced me, and I had actually mentioned this ligament about treating it, and that paused him, pulled us into a room, and we had a long discussion about that ligament in particular, because as he and I both talked about, it's not often mentioned in the literature, and it's not often mentioned as far as treatment protocols and angles, and he himself, doing spine work for 30 years, found that ligament was a problem, and I let him know how I manually decompress it in the UP, and he thought that was a pretty cool thing, and then so we exchanged some other notes. But anyway, the ligament is a very important part of the equation in addition to the bone when it comes to rotor-rooter jobs. So my observation is this: patients tend to do fairly well with this for a few years and sometimes longer. However, over time, the spinal nerve sometimes gets crowded again. The bone grows or the ligament thickens again, scar tissue, and another surgery or two may be needed to perform. My estimate from what I've witnessed, and this is close to the literature as well too, is somewhere around 60 to 70% effective for the treatments of patients. And if I were you, in the back of my mind, I would be struggling a little bit going, and it's still a struggle, but like, wait a second, if I've got crowded bone, fragment, nerves, they go in there and rotor-rooter. If I think about like a plumbing job, that should just open up the spigot, and it should be 100% effective. You rotor-rooter your plumbing at your house. If you go in there and just get all that hair and gunk out of the way, or something's plugging up your plumbing, and then now all of a sudden the drain works, this should be the same thing for the spinal canal. Unfortunately, because of the dynamics and the mechanics of the spine itself, that's why we don't see 100% effective on there. There's just too many other variables going on around the spine, but the concept is get it cleaned out. And yes, it can work in 60 to 70% of the cases. Problems do occur in about a third-ish of the cases. Most of it, sometimes not enough bone material removed. Maybe the surgeon was being a little more conservative. Another issue remains is the fact that there's stenosis in other areas that weren't touched. So you might feel good because they got rid of the main offending part of the stenosis there. They cleaned that up for you. But they left the rest of it alone. So you feel good, it lingers, and it gives you a false sense of security, and then bang, you overload the spine and you're right back to the pain syndrome you had, but at a different level. So again, the surgery removed the pain. The stenosis is still there in other areas. You feel great, and wham, you're right back to where you started again at a different level of the spine. Also, caution on that side of the equation. If you have other types of stenosis in your back, like central canal, which would be the middle, I call it the north-south tube, the main tube of the spine, and that was not cleaned up because maybe it wasn't as bad, that's where you have to be very careful going to the right practitioner to make sure that they know how to handle post-surgical backs. Unfortunately, I've had to do evaluations of cases of new patients who had a successful spine surgery, went to a practitioner of sorts, mechanical practitioner, and we're just going to lop in chiropractor, PT, and had too much of aggressive treatments to the spine afterwards, and it caused some major problems, and those aren't easy to fix up. And they're miserable, sometimes more miserable than the surgery itself. So again, your choice of practitioners, of who you rehabilitate with or see afterwards, is critical. And we're going to jump even into ahead of that, how to even choose the right spine surgeon coming up in just a little bit. The third type of surgery, and the most commonly performed, is another one, is the spinal fusion. Now, this is used to permanently connect two or more vertebrae in your spine, eliminating the motion between them. The fusion involves techniques designed to mimic the normal healing of the process of, let's say, broken bones. During the fusion, the surgeon places bone or bone-like material within the space between the two vertebrae. Metal plates and screws and rods may be used to hold the vertebrae together. There's lots of little mechanisms they use so you can heal into one solid unit. That's where you got to think. It's basically trying to take and make it a block. My observation, it helps some. I sent a guy from the county for a big spinal fusion surgery, but that was after we had discussed it for probably 2 years. It was a 6-month recovery of misery and 6-month recovery after that of feeling somewhat better, and then after a year he was feeling better, but we had a long discussion about that. That was a fusion surgery, so it's a big one. Now, I heard one surgeon tell one of my patients, expect 30-30-30 in certain cases, meaning 30% get better, 30% no change, and 30% get worse. And again, I'd say that's pretty close to accurate. So 60%-ish, either neutral or no difference. So keep those statistics in mind. I read a report on a patient from Mayo Clinic who was offered the surgery to the patient, and they said, we're going to give you about 40% effectiveness on this case. A random side comment, there are a few surgeons that will insert a spring-loaded disc into the deteriorated area and rather than fuse it. And this can be an option if you're a candidate. A spring-loaded disc basically restores the area in the back and spine to its normal self, almost. There are risks and barriers, but overall, the spring-loaded or artificial disc in the lumbar spine, it is probably the best of the best that I've seen as far as outcomes go. Unfortunately, it's rarely done or offered, and there are various reasons for that. And we don't have time to get in there, but a spring-loaded disc works really good. I do want to harken back a little bit, though, as far as the spine surgery realm. If you remember from way back in the day, well, 10 years, not quite back in the 97 snowstorm, but 10 years ago, there was an enormous amount of marketing done by a place called the Laser Spine Institute. And they had a little Band-Aid, across somebody's back, 1-inch incision, and they use the term laser. So they were promoting it. I mean, we're talking, it was all over the place, and patients were going down there. Sometimes insurance didn't pay for it, so patients were paying out of pocket for it. And it seemed good on the surface. Laser Spine Institute. Wonderful name. Anytime you stick laser in front of something, it's going to sound scientific. And, you know, if I put laser in front of whatever, Laser Larry, well, all of a sudden now, I just sound like I'm from the scientific world, right? So Laser Spine Institute really got a lot of traction early on, but there was a problem. It's out of business now. Hundreds of millions of dollars in lawsuits. 9 surgeons came forward claiming the company was doing surgeries that were unnecessary or inappropriate. It was gimmick medicine. And it was huge for, I would say, the first third of when I was in practice. So you got to watch gimmick medicine when it comes to this stuff, and you think, how could that exist? It existed. Gimmick medicine existed. That's why that business is no longer there anymore. And again, as I said, some surgeons came forward and said it was gimmick medicine. Did some work? Yes, but overall, for the ones that didn't and what they were doing. Let me pause for a second here. We're going to wrap up a few things before we get to the next segment. If you log on to www.wikb.com, you scroll down at the Ask Dr. Larry question part. You fill in the stuff. If you have a question about any type of spine, lumbar spine surgery, that's the topic for today, by all means, fill that out. Ask the question. I will respond to you with an answer for free. That's a benefit that WIKB, by me broadcasting on here, is offering to you as a public service. That's what it is. It's a public service. It's advice. So let's not take it any further than that, but it's a free service. WIKB.com. Click the Ask Dr. Larry, fill out the stuff, and they will send it over to me. So lumbar fusion, spinal fusion, I think you've got your minds wrapped around that. And fusion is typically considered when there's structural instability in the spine, severe degenerative disc collapse, slippage of the vertebrae, fractures sometimes in cases, but not all fractures, by the way. Some case of spinal deformity, scoliosis, and nerve compressions with instability. That's typically where they're going in there to try to stabilize the area, reduce the pain by abnormal motions and pressures, and hopefully bring you back to somewhat of a normal stance. But again, this mostly gets the water cooler talk where so-and-so had back surgery and it just didn't go well. That's usually the spinal fusion side. And if you remember from a year ago, I had a young neurosurgeon on the show, and we discussed spinal surgery. And here's a new guy coming out doing surgeries, and I said, okay, anything new? What did you learn? And he said, honestly, Dr. Larry, it still boils down to the 3 I just gave you. That's mostly what my basic hitting drill is. Nothing is really enhanced overall when it boils down to it. Maybe there's some little things we can do differently. Some of the hardware has improved, but ultimately we're just doing the basic 3 as far as lumbar spinal surgery goes. So again, more surgeries being done, but not necessarily better outcomes, and not a whole lot of ton of advancement in there. And that's when it really gets into what we're going to get to in the next segment about picking and choosing the right surgeon based on certain characteristics. Also making sure you are properly pre-screened as far as getting a surgery like this goes. All of that comes into play and is very important to make sure you are the right candidate. So we're going to do that. Characteristics, how to know if you should get spine surgery, some benchmarks, check boxes, things that you need to know, or at least if you know someone that might be getting one, or if you just log this in your brain for down the road, we're going to do that when we get back from the break. Stay tuned. You're listening to the Dr. Larry Radio Show.
We'll be right back with Dr. Larry.
Here's your Iron River and surrounding area forecast. Chance of scattered snow showers this afternoon. Otherwise, cloudy skies with a few peaks of sun. Daytime highs approaching 36. Winds out of the north, 8 to 15 miles per hour. Partly cloudy skies. Tonight, lows dip down to about 9 above. A dusting of snow today with another dusting tomorrow. From the Weatherology Weather Center, I'm meteorologist Jennifer Wojcicki on WIKB. Right now, 34.
Stevens Real Estate has been the top producing real estate company ever since 2009. With convenient locations in Iron River, Florence, and Iron Mountain, buying and selling real estate has never been easier. Our team of pros is your team of pros, trusted since 1979.
Does your financial advisor take the time to really listen to you? Is your financial strategy personalized to you and your family? Will your financial advisor be there as your life and financial situations change? When you work with Ryan O'Grady, your Crystal Falls Edward Jones financial advisor, he focuses on what's important to you. You work together and use an established process to create a personalized financial strategy, backed by the advice, tools, and resources to help you reach your goals. And you can partner long-term to help your strategy stay on track. Contact Ryan today at 906-875-3833. Edward Jones, member SIPC.
Spring is in the air, and Jensen Akins is a perfect place to help you spruce up your appliances to celebrate. We've got all the brand name appliances you trust, like Whirlpool, Maytag, and Amana, all set to brighten your home and make the chores in your life so much easier. And Jensen Akins doesn't just sell Whirlpool appliances, we service them as well. That's at Jensen Akins of Conover, of course.
Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. Surgery and back surgeons. When you need to have spine surgery, I or any referring doctor should make a conscious, well thought out referral. A conscious, well thought out referral, not a knee-jerk referral, not a subconscious referral, which would be a good match for you, the patient, and the problem. What is reality, though, is like in any profession, not all spine surgeons are created equal. There are some small differences and some very big differences when it comes to cases, which translates to a successful visit, a successful surgery, or a failure. You would assume that this is all done for you. You would assume that this should already be scrubbed. But I'll tell you, as a witness, it is not. I just went over a surgical consultation case, pre-surgical consultation case this week. Something that I have to do frequently for people, either pre or post, if I get them early enough. And this exact discussion is kind of what we were going through because it required long, conscious, well thought out matching for if you should have some type of spinal surgery and who should do it. So let's go over 3 unique characteristics of spine surgeons to help you make a decision on what to choose. And maybe you could cross-pollinate this into other surgeons as well too. So I'll just kind of scatter the seeds a little bit, but let's of course stay in our lane and talk about spine surgery. First is characteristic is specialty. There are neurospine surgeons called neurosurgeons, and there are orthopedic spine surgeons. They are essentially trained the same and do many of the same surgeries. However, there's a subtle difference you should know. Here's the best analogy to split the difference for you. The neurosurgeon is like an electrician of the spine, and the orthopedic spine surgeon is like a carpenter or a contractor of the spine. Now, generally, this doesn't matter in some cases because they both can wear each hat, except when it comes to specific things. I'll give you examples of patients so you get the idea. Case 1 was a middle-aged male with back spasms and numbness in his leg. Nothing worked. He couldn't be fixed by non-operative measures, so I had a neurosurgeon look at his MRI, which he said was fine because all the wiring looked good. Right there, pause, come back. Typically what happens is there's a stop. Patients go, well, I went to a surgeon, they said I'm fine, but why am I still in miserable pain? What I wanted to do is I wanted to root out and rule out if there was any neurological problems with the patient first because he had distribution of pain into his legs, so we went with the electrician first. Electrician says all is good. Now, did the electrician then refer him to a carpenter-style surgeon to make sure the carpentry was good? No. So the guy comes back, he's miserable. I said, hang on a second, don't get upset. We're going to get a second opinion from an orthopedic spine surgeon who took one look at his spine and said, the whole wiring looks good, but the carpentry looks terrible. So he operated, did some carpentry work on the guy's spine. His symptoms improved by 85% and still held on for 10 years post-surgery. Case 2 was a middle-aged male with excruciating leg pain. I sent him to an orthopedic spine surgeon who said carpentry looks good, but the guy was miserable. And they got a second opinion from a neurosurgeon who said that the wiring was wrong and fixed the wiring and the guy improved. And the third and final case, just for a reference point, and this one was very interesting and kind of says the whole matter. A 19-year-old slip and fall on ice, again this is a while back, relatively disabled, failed spine injections, failed chiropractic, failed physical therapy, you name it. 2 prominent neurosurgeons said no fixing. This is a permanent disability case. Once I got the patient in as a new patient after all that, after long discussions and 6 months, I got a hold of an orthopedic spine surgeon, looked at the case, and he said, I think I can go in and fix what I need to fix. Translation to you is, I can fix the carpentry. So he did, and fast forward years later, the young man is fine. It's as if he never had a disability. Big difference between long-term disability at 19 years old to totally fine, no issues, no problems. That's the difference between the specialties. But again, if you're hearing the undercurrent here, the one doesn't refer to the other. Somebody, some practitioner has to be in there and recognize the two. Still not training as far as even in the chiropractic side of things. I don't see it terribly often on the primary care side of things, but now you are armed with that knowledge, so you have the information, and I find that's the best way to go. If I take and translate this out to you, then you deploy and you go out and you have this and you know, or you can make the recommendation. You have this in your brain. So that's a difference in specialty. And again, the bummer is they don't often recognize that one's a carpenter and one's an electrician. My son, the electrician apprentice, they know who the plumbers are. They know who the electricians are, and they know who the carpenters are, and they know who the laborers are. So in the trades, it's divvied up nicely. Yeah, an electrician can do some carpentry. Of course, they all can do a little bit of that, but they stay away from the big stuff that the carpenters have to do and vice versa. The second characteristic is style or personality. Now, some surgeons, now we're getting into a little bit of the dating game with Chuck Woolery here. Yes, it's a little bit of the dating game. Some surgeons are soft. They have a disarming demeanor. Some are abrupt and curt and have an unkind demeanor. And some are just totally indifferent altogether. Nothing. You get nothing. These personalities do come into play in unique and unwritten ways. For example, you may be a little overweight. You might be a lot overweight. You might smoke. You might be a bit of a whiner. You might be all of the above. If you get into an abrupt, curt, and unkind surgeon with some of your physical or personal quirks, and your visit then becomes miserable, and you immediately become untrusting of the surgeon, even if you opt to go to the surgeon. So yes, after the characteristics, I then, and doctors should, or your referring source should, do a little bit of a personality match. I've seen patients come back, men, angry if they got referred to somebody, if I'm doing a new case workup, or ladies who, if I'm going through their case history, and if they went to a referral surgeon going, that guy was a total jerk. And this is what he said, I was overweight, I shouldn't be smoking. And I say, hold on a second. Okay, I understand. That doesn't mean you don't need surgery. It just means we have to get you the right surgeon that's going to understand and look past some of this and still get what you need done. So if you're catching that point as well. Now, you think, okay, well, I just want to go to a softie, or I don't care what their bedside is. And I understand that. You might not care, and that's perfectly fine. If you don't give a rip, they don't either. So you just want to go who the best is. They do have their little quirks and their different personality styles. So like, for example, a soft style personality may not be willing to go in and take on a complex, difficult case. A technical surgeon that has some creativity but is curt and unkind could care less because he's all business. He's going to get in there and he's going to dig away and he's going to get to the problem, where the softie may be like, well, maybe we shouldn't do surgery then. And yet you still could be fixed by a surgical outcome. So that's why you got to kind of too understand the little bit of the characteristics. The third and final is, do they follow up with you after the surgery if something doesn't go right? What's their reputation? Or do they drop you like a bad date? The last thing you need or want is to have a surgery, get a complication, or something doesn't get totally fixed and you get dropped like a bad habit. This is real world, and I've seen it happen. I take this factor into consideration when making referrals for patients, and so should any referring doctor as well. If there are complications, What has that surgeon done when things haven't gone right, and how have they treated the bulk of patients? And I pay attention to that stuff. And that puts them up the list or down the list or off the list. Just that alone. A very talented surgeon could be lousy when things go wrong, and that puts them way down the list, if at all. Keep those things in mind when you're considering having surgery. Now, finally, for the vast majority of you, I've got a couple of minutes to wrap this up here. What I'm going to talk about won't apply. It's failed back surgery syndrome. So hopefully most of you don't even need surgery. And hopefully you're just kind of listening to this going, okay, good, check off the points, good to know, glad I have the information, but this doesn't apply. I want to roll through what failed back surgery symptoms are. So this is what they are so you have and understand it. New pain at a level different than the location treated, inability to recuperate or recover, restricted mobility, sharp stabbing back pain, sound like an auctioneer here, numbness or pain radiating down to the lower back and legs, back spasms. Things can happen worse after the surgery. That's a failed back surgery. Doesn't necessarily mean something went wrong in the surgical operating room. It just means that it failed. And those are the symptoms. I just had to do a case a couple of months ago of a failed back surgery. Quote from the patient, I went in with pain and I could walk, and I came out without pain and now I can't walk. That's a failed back surgery. And hopefully we can get some things corrected. Not sure on that one. Conservative estimates are failure can happen up to 20 to 40%. So if you just kind of draw a line in the middle, say 30% in certain cases, or 29.2 are some of the data points. So again, why does it happen? Spines are complicated animals. It's not as easy as roto-rootering. It's not as easy as just going in and chipping off a little piece of lime or calcium there. Spines, lower spines, are complicated animals. There's lots of different dynamics going on. A couple of reasons why it can happen. Yes, there's some improper preoperative patient selection, and that's the big one. It's best to be ahead of schedule, pre-selected, going through the necessary steps, having somebody walk you through it, and going through this. And I would say about the length of this radio show is about the time I spend on the final discussion before they even get to the surgeon's office and talk to them. And then we do another one like this. So this is one of those things where I don't shorten that visit at all. It's actually one reason why I got behind yesterday, because I was trying to go through this with somebody. So that's why you're getting it today. And there's some other reasons why back surgeries fail, scar tissue, and I'll probably try to run through that list next week. So you can ask around, again, a review, the types of surgeries, their unique characteristics, 3 of those. Proper screening, one practitioner that you completely trust can take you through it all, who knows your spine, understands all your treatment possibilities that have been exhausted, explains what you just heard, reviews the opinion of the surgeons with you after you meet with the surgeon and before you make a decision, you have the surgery. You're properly evaluated. You trust the practitioner. You basically need a quarterback that knows how to, or a traffic cop. Now, it's been 5 years since I've done this show. I had to look back. I usually try to do it every year or so, but it's been 5 years since I've done the show, and it has not slowed down as far as this type of consultation and problems that I see out there at selecting proper back surgeons for back. So I'll try to do the show a little more often. It got shelved, and I'll try to resurrect it and bring it back as far as the type of show goes, because it's very, very important to hear this and understand what it means, because back surgery, as you know, oh boy, back surgery. But if you're in a case, in a situation, or you know somebody, you definitely want to make sure that every box is checked off and make sure you're pre-screened properly. Okay, upcoming commentary, announcements, and our tip and trick of the week after the break. This is the Dr. Larry Radio Show.
We'll be right back with Dr. Larry.
What's cooking in your community? Head to one of these fine establishments for your next bite or beverage.
Alpha Michigan Brewing Company on the Circle in Alpha opens at 4 Wednesday through Friday and noon on Saturdays and Sundays. Call 920-358-9551 or go to alphamichiganbeer.com or Facebook for tap menu and events.
The Habit Bar and Grill, Highway A in Nelma, Wisconsin on the Snowmobile Trail, and offering premium gas and daily specials. Open 10 a.m. 7 days a week. Call The Habit, 715-545-2646.
The Horseshoe Bar, downtown Amasa, opens at noon, 7 days a week. Burgers, sandwiches, nachos, crazy broad specialty homemade pizzas, and deep fryer snacks too. It always tastes better at the Horseshoe Bar, downtown Amasa.
The Local Eats List from your friends at WIKB WFER.
I would never recommend buying a home without having the water tested first. It's cool, it's clear, it looks clean. Oh, it tastes good. Well, what's really in it? And we just recommend that you check it out. I'm Jennifer Toivonen. I'm a co-lab director at Whitewater Associates of Amasa. Coliform bacteria, lead, arsenic, nitrates, nitrites. You want to be sure that water is safe. I would recommend giving us a call. That way we can tailor the kit that we send to you for what you need. 906-822-7889. Give us a call.
This is Lois.
Your healthcare should be about what's best for
and you're
you.
listening to
Yet too often,
Dr.
healthcare
Larry
professionals
Radio.
focus on keeping patients within their system, including who they refer you to. I'm Dr. Jason Klein, orthopedic surgeon and physician owner at OSMS. You should be seen by who you want, and you can be. At OSMS, our focus is on providing you with the highest quality of care in a safe environment. The best part is, you usually don't need a referral for orthopedic care. Learn more at askforosms.com.
Break's over. Time to get cracking once again with Dr. Larry.
Okay, a couple of things before we wrap up the show, a little commentary, and we'll get to the tip and trick. Pistachios. Pistachios. I like pistachios. Do you like pistachios? Pistachios naturally slow down how fast you eat if you shell them. Most snack foods are designed to disappear quickly. Pistachios are different if you get the shelled kind. You crack the shell, you take out the nut, and you eat it. It's a tiny little delay sometimes that changes. That said, I no longer buy shelled pistachios. How about you? They now have pre-shelled pistachios. I do like those much better. So let's not put that against the pistachio company. Because I'm so glad somebody's shelling it for me. That way I can rifle down a few more pistachios with all that labor. Now, what's the fun thing about pistachios? People often assume nuts are high in calories, but pistachios are among the lowest calorie nuts per serving. A typical 1 ounce portion contains about 160 calories, 6 grams of protein, 3 grams of fiber, mostly healthy unsaturated fats. That combo, protein, fiber, healthy fats, is exactly what helps us feel full after eating. They're surprisingly good for blood sugar balance. Unlike many snack foods, pistachios do not spike your blood sugar. In fact, when pistachios are eaten along with carbohydrate foods, research shows that they can help reduce the size of the blood sugar spike after meals. That means something simple like adding a little pistachios alongside a snack can help your body handle blood sugar a little more smoothly. We always have pistachios at our office. A lot of times at the house. When's the last time you picked up some pistachios? It was fun. How about that green color? It's a little weird at first when you look at a pistachio because we think nuts are brown. Nuts, brown nut. Pistachios are green. I'm not sure about pistachio ice cream, though. I haven't tried it. Not that I remember. Well, so you notice that bright green color? These are the same nutrients that are known for supporting eye health. It's like a supplement within a nut there. Has vitamin E compounds that contribute to overall antioxidant. They have meaningful potassium. So if I say pop quiz, potassium, are you thinking bananas or pistachios? You can start thinking about pistachios too. They have a lot of potassium. And just like any nut, pistachios are calorie dense, but just not as much as some other ones. Pistachios are fun. Okay, don't forget to check out the link on WIKB.com. Like I mentioned earlier, don't forget to check out my website, drlarryradio.com. You'll see 3 tabs there. For patients, for listeners, and for syndications. Don't forget to check out that website, drlarry radio.com. And you can check out all the recent shows I have. You'll see a big tab there. You can click that and listen to anything that I've done over the last couple of years. It's all been uploaded. Thanks to the crew here at WIKB. They do record every show, and I have the option of putting it out and broadcast it. And on all the other platforms as well, too. We're on Spotify and Apple, and we're getting into the thousands of downloads across the nation and world. Yeah, we're getting lots of downloads. In some places I had to look up. Kind of funny. Seems still, though, Michigan, Colorado, California, Those seem to be places that download different variations of the show. Kind of weird that way. All right. It was a commentary, man. I'm winding down on this cloudy, wintry day. Snap into the Tim. He's going to help us out. He's jumping up the broadcast booth. I'm heading out center stage for the demo. Today, we're going to learn a simple self-check for carpal tunnel. Thousands of times. He's going to be a pro. Go, Tim. We got our Sennheisers on, man. And that just blew my eardrums out. Bass. I guess there's a lot of bass in these headsets we got on. Okay, let's go. Call it out for him.
All right, Dr. Larry is, he's, instead of doing the praying motion, it's kind of like the opposite of the praying motion with his hands put together at a 90-degree angle.
Yeah, man.
His forehand, arm.
You got it. Good job. So what should you feel? You kind of like he said the opposite praying position. Looks like the Van Halen sign from back in the 80s, right? You're basically smushing the backs of your wrists and numbness and tingling into the fingertips. Fundamentally, probably the number one tool I use for carpal tunnel. Hold it there for about 30 seconds. If your fingertips start to go numb, and about 5 seconds in, my left middle finger is starting to go numb. Right one feels good. Now I'm starting to get a little more numb. That'll start letting you know if you've got mild to moderate carpal tunnel. If it gets to the severe, that's actually where you would need to have some type of evaluation, like a nerve test, etc. Here's your test for carpal tunnel. There's another one we can do. We'll do it another time. The term's called the Phelan's test. I'm not going to pop quiz you on it, but that's what they make us memorize, these dumb names, and then we have to put it on your chart. Phelan's test, PH with a PH. Who knows what that Phelan's test? How about the wrist kiss test? I don't know. Something more practical. It's people that come up with these test names. Ugh. Schleppmans. There's a Schleppmans test. Tim's an engineer. He doesn't even know what a Schleppmans test is. I wouldn't know what it is. Maybe we'll do a Schleppmans test down the road. We got them all. Somebody with a name. I guess if you have a road after your name, that's kind of cooler than having a orthopedic test after your name. I think it would be cool to have we see it around here. Domboski Road, right? You got all these road names after people have been here for a while. That's kind of cool. Tim, you don't have a road named after you, do you? No? Okay. Let me know if you do. We'll talk about it. Okay, folks. That's the show. Back surgeries. Hopefully you don't need one. Log in what I said. Remember, you can listen to me live right here every week to learn how to achieve a better back and better health. Or if you're having a pain or problem, I'm here to help. My number at the office is 906-875-3215. Have a good day, man on the board. See you next week, everybody.